as recent times have come, the contrast X-rays are not that popular. So yeah, good afternoon once again. And yesterday I could not take class because I was out, and today I'm back from Bangalore and a little bit sleepy. But yeah, hopefully it'll be a good class, and we'll begin. Yeah, hope the screen is being shared and I'm clear and audible. If anywhere any doubts you
Yes,
have,
sir.
you can put it in the chat box. Is everyone clear? Is it audible?
Yes, sir.
Okay, yeah, thank you, Adityan. We'll continue. Today's topic for the day is modern diagnosis of radiology. Even though the name says modern radiology, but contrast radiology is an old part of radiology that we'll be dealing today. Before we go into contrast radiology, why do you need to know principles of radiology? One thing is when you are not sure, may it be contrast radiology or any investigations. Usually, clinically, when you cannot get into a cut through diagnosis, you go into clinical investigations. So is the case with the radiology, because what you see is easier to correlate with the clinical features that you will be investigating in the patient. So first thing is the patient management. Second is the interpretation, that is how severe or how bad is the disease and how much grade of treatment does the patient require. Third is a definitive diagnosis so that you can put in interventions. And fourth is planning the treatment, that is you have started the treatment and does it require any modifications, or is the treatment working, is what is business. And the fifth, of course, is to score marks, because radiology is an important subject, and present day radiology is a developing field, and more intervention radiology topics are coming up these days. We have discussed this already. Can anybody tell me what is the X-ray on the screen? It's a normal X-ray. Which part is seen? What is seen? Can somebody point it out?
Spine and hip bone.
You can see the spine. Basically, abdominal X-ray I've seen. So you can see the lumbosacral spine. The abdominal gases are there. Normal pelvis is there, though the hip joint is not visible, and the lower ribs are seen. This is a normal X-ray, of course, of the spine. Yeah. What we are coming into contrast radiography, and as the name suggests, use of contrast is always there. What are the properties of contrast? Do you think, even though it's there on the board, are important when you administer into a patient? Can somebody talk about it? Like you can tell what contrast features are very important. Okay, Govindan is telling me screen is invisible. Sorry again. Yeah, sorry about that. The screen is visible now.
Yes, sir.
Okay. What are the properties of contrast do we need when we administer to a patient? Can you use anything just because it's colorful? Yeah,
Which
come
is
on.
opaque and translucent, sir.
Yeah, opaque to an X-ray. First thing, right? Next.
Translucent.
Yeah, of course it has to be transparent, radio opaque, and it can be colored or transparent. Next, it should not be poisonous, right? Because you are administering to a patient, and like that.
Easily
Can you name?
eliminated.
Yeah, okay, easily available. Okay, cheaper. Fine. Next. Okay, it should be excreted from the body, because anything that you administer, it will cause its harmful effects if it stays in the body, right? So it has to be excreted. Next point you can say is that it should not be chained to one form. Suppose you administer some drug, which is you are using as a contrast. If it goes turns into something else, it is problematic because you cannot reverse it. read it. First thing, it should be easy to administer and it should not be toxic. That is, it should be stable. It should not disintegrate or harm the patient. Then the next thing we want is it should be concentrated in the area where you want. Suppose you want to study the kidney, the contrast which you give should be more specific to the kidney. And when necessary, it should be eliminated because it should not stay in the body so that it will cause. And other things are it should be not be carcinogenic because most of the radio contrast which people tried earlier were carcinogenic. That is, they can cause cancers, and they should be cost effective. These are some points of ideal contrast which are there. However, such ideal contrast does not exist, and either one or the other bad features will be there in a contrast. Coming to the first type of contrast studies, we will study about barium. Barium is a contrast material which is used for studying GIT. I had asked Ganesh to tell you regarding to read basics of GIT so that you can know where which part is there and how it will look on a contrast X-ray. The problem with the imaging of GIT other than bones is can anybody tell me why we can't picturize GIT and compared to bones?
Calcium content.
A radio opaque thing which will not let X-rays pass, but whereas GIT or the mucosa, the skin, are not such structures which will let X-rays pass. So on the film, there is no image formed. Right. So we have first of all barium studies. Uh, Usually it is barium sulfate, which can be taken by mouth, or it can be taken as a semi-solid diet, that is called a barium meal, or it can be taken as barium enema, which is administered through rectum. These are three common ways through which barium can be administered. However, what is the precaution you have to take when you are giving barium to a patient? One common thing: can we give barium if his intestines are ruptured, like he is having a peritonitis or his intestines are torn? Can you give barium?
No, sir.
So that is wrong. You cannot give because barium itself will cause allergic reactions and peritonitis. That is, it will cause more inflammation because barium should remain in the vessel gut wall. If it goes out of the gut wall, it can damage structures which are staying outside. Because in the gut wall there is something called as the mucosa, which is protecting the barium from preventing it from going outside. So you should not administer barium in patients who have had a perforated stomach or a perforated small intestine or large intestine. Okay, this is what you have to take care. Next, coming to the first thing, that is barium swallow. Here, basically, you are swallowing the barium to study most of the esophagus and the stomach, that is the upper GIT. However, the upper can you differentiate between where is the upper GIT and where is the lower GIT? What ligament? There is one ligament which differentiates upper GIT and lower GIT. Can you think and tell me if you know?
Sir.
Okay, there is one ligament near the small intestine which is called as ligament of Treitz. Okay, any structure which is above that ligament of Treitz is known as upper GIT, and anything which is lower that is known as lower GIT. Okay, coming to barium swallow, here we from the oral cavity to the fundus. What is fundus?
The upper part of the stomach.
Yeah, it's a part of the stomach. Yeah, these are used barium swallows to picturize the same. When can we do this barium swallow? First thing is you have dysphagia. Dysphagia is difficulty in swallowing, and then there is obstruction. Okay, the patient is not able to swallow or the food is not going into stomach. You can do a barium swallow to see where the obstruction is. Next is odynophagia. What is odynophagia? Dysphagia is difficulty in swallowing. What is odynophagia? It's okay.
Painful, sir.
You are just too young. Yeah, painful. Very right. It's. I'll tell you if you don't know, but if you know, it is very nice, and I'll be happy if you answer. Okay, that's very good of you. And yeah, also is painful swallowing. Okay, for this because when there is painful swallowing, you want to rule out if there is any ulcer or trauma to the structure which is being painful. Next is mediastinal mass. What happens is mediastinal masses will press on the esophagus. So when you do a swallow, the mediastinal mass will push the esophagus to the other side, causing filling defects. Then there is motility disorders such as achalasia cardia and scleroderma, where the lower esophagus is non-motile, so the food is dumped in the lower esophagus, and basically it forms like a stomach-like structure, and there is difficulty in passing the food from esophagus to the stomach. Uh, Indications we have seen. Now coming to the contraindications where you should not be doing a barium swallow. As I told earlier, the perforation. What will happen? You do a perforation and you do a barium, it can go into thorax or it can go into the abdomen, which is very dangerous. Uh, Another thing is tracheoesophageal fistula. What is a fistula?
Combining two things.
Two things, two viscous or two hollow cavities is known as fistula. What is a sinus? Just have a guess.
Hollow space.
What is a sinus? Sorry, Vishnu, I didn't hear you.
Hollow space, sir.
Yeah,
Air-filled
no,
cavity.
anything that is connecting it to the outside, that is a sinus. Okay, so may it be a hollow cavity, may it be an organ, may it be a gut, that is a sinus. But a fistula connects two closed cavities usually. That is, it will connect two viscera or two closed cavities, GIT, and suppose there is a connection between an esophagus and, as we saw in the example, trachea, it is called as tracheoesophageal fistula. And another important thing is, over the time, usually fistulas are epithelial lined. May not be so in sinuses because sinuses take more time for epithelialization. Okay, what do? You give a mouthful of contrast of barium sulfate and you observe radiologically. How do you observe? Through serial X-rays. Okay, and you expose the regions of which you want to know. Then how do you interpret? If there is a long segment of narrowing, that is, there is normal esophagus and then there is narrowing like this. This is filled white, okay, by the barium that you have swallowed. This this long segment of narrowing, it could be because of a stricture. And another thing is scleroderma, where there is absence of the motor neurons of the esophagus. So what happens? In the normal esophagus, which is cylindrical, basically, there is collection of this white material. Okay, this can be seen in some normal interpretations. And if there is an ulcer, how will an ulcer present? Ulcer will present like a defect like this. So basically, this is an ulcer. If there is a malignancy, suppose this is a normal esophagus, what malignancy or some growth, this will grow as a rough area. This is could be. You cannot say what it is definitive. Always the gold standard will be a biopsy because you take the tissue out and know what it is. But if you are suspecting, suppose your patient is a known smoker, he always complains of gastritis, and you want to rule out a GERD, you will know that there is lower dilatation of the esophagus because of the acid that is coming out from the stomach. So you can correlate with your study. Next, we'll see the images later as they come along. Next, we'll go to a bronchogram. Uh, this is a picture of uh, where you picturize the bronchial tree using a radioactive substance. Okay, this is a short topic, so I put it in the middle. Sorry for that. And what you do, you put the contrast. How do you administer? Suppose if you want to have a, like we knew that renal images through contrast, we gave IV. If you want to picturize a bronchus or a bronchial tree, how do you think we should administer the contrast?
Oral,
You
sir.
should give it through the respiratory tree only. No. You should give for a. I'm asking about a bronchogram. If it is for a barium enema, a barium meal, you are right. Or a barium swallow, you have to go through the oral route. If you want to picturize the tree, respiratory tree, you need to go through the nasal or basically the tracheal route to picturize the bronchus. How do you do a bronchoscope? There is a structure called as a bronchoscope, which goes into the trachea and then you administer the drug or the contrast. This is a picture of the bronchial tree, which is normally this is how normal contrast bronchogram will look like. Why this is important is this is not routinely done these days. However, filling defects or if the bronchial tree is blocked, it will look more darker. That is, the white contrast will not reach that area. Or if there is a lung collapse, this part of the lung, if it is collapsed, this won't be seen. This is how it will be seen. There is something called as air bronchograms. These are seen in some common diseases. Okay, air bronchogram here the contrast material is air itself, but there is a blockage for the normal path of air. So that part of the diseased lung will look like it is having a bronchial tree which is prominent. These are seen in normal chest X-rays. It could be because of lung consolidation. Contrast material, I repeat, air bronchograms are normally seen in some diseases. It can present even in normal disease when you take an X-ray. But why do you call it air bronchogram? Because these are not contrast. Air itself is acting like a contrast material where you can picturize the bronchial tree. Uh, Okay, come up to this. I wanted to take up in large, but since it has come here, I think there is a mix up of slides. Okay, next we'll go to myelography. Myelography is a real-time X-ray of the spinal canal, where you can see the spinal nerves and the spinal cord which is traveling through it through fluoroscopy or radioscopy. Here, where do you think we have to put the contrast material to see the spinal cord? Can you guess where we have to put the contrast material?
Citru lumbar puncture.
Yeah, exactly.
CSF.
So lumbar puncture. Yeah, to the CFS you have to go and you have to picturize it. This can be done in a process known as myelography or a myelogram, where you as you insert the needle into the lumbar area or the spinal canal, and then you see where the contrast is moving. As it is moving, you picturize again and again. What level can someone tell me what level you have to put the lumbar needle to enter into the spinal cord safe area? Normally, we enter and anesthetize the patient there, spinal anesthesia or something. What level?
L2, L3.
Yeah, L2, L3 or L3, L4. And in children, it will be one step higher, okay? Because children, the spinal cord is smaller. And the chorda equina begins much earlier, so you can go one step higher in children. That is very nice, yeah. And that is myelography. And what is the benefits? It's safe and painless. And here the contrast material is injected into the spinal canal only. And hence you can see different areas where there is a nerve root compression or a disc bulge, or if there is any compression on the spinal cord canal itself or the spinal cord itself, it will look like a filling defect as we saw in other contrast. And once the radiographic image is obtained, there is no more radiation remaining. Unlike nuclear radiation or something where nuclear studies are done, where radiation remains in the body, some part. Also, some risk with this slight chance of cancer because of X-ray. All X-rays are turned into cancer or something because X-rays are common and we have been using in medical field ever since. And possible risk of cancer and X-ray association have not yet been established. Of course, they are cancerous, okay, if overexposed, and we have to avoid such X-rays in pregnant or a woman who is carrying. And the effective dose of radiation varies. That is, it's a trial and error method. So the dose of X-ray that you have to provide is only checked after you get one X-ray, and you increase or decrease the dose based on the clarity of the image. And some people have had associations of headache. Why do they have headache? Could somebody guess what could be possible reason why they could have headache? We have done and we have punctured and we have put the contrast material. Why? What could be the reason for a headache?
Suppose it is brain.
So intracranial pressure.
Pressure increases.
Yeah, intracranial pressure going out. Yeah, right. Very good. Intracranial pressure could be going down. He could have lost a lot of CSF. Other thing is you would have punctured one of the arteries which is there, and it may be compressing on the spinal cord, causing increase in intracranial pressure. Both increase in intracranial pressure and decrease will cause headaches. Okay. Other thing is it could be psychological because we have seen a lot of patients who, after a spinal we have given and operation is done, they come back after 1 or 2 years telling that it is causing me backache, which is unlikely because if the backache has to be there, it should be an immediate symptom. It cannot be up 2 or 3 years. It could be psychological also. Okay, this is another risk is you and a person who is not an expert in doing LP or putting a needle into the canal can puncture different areas of the spine, or he could puncture the spinal cord itself. Okay. Another thing is adverse reactions using injection, which can happen in any contrast. Adverse reaction can present as itching, sneezing, nausea, anxiety, all that we know, and other complications such as injury to spinal cord or meninges. Or other thing is if you are not taking proper aseptic precaution, you can put in an infection into the spinal cord and it can present as meningitis. Meningitis is inflammation of the brain parenchyma or the layers covering it. Next thing is another disadvantage is that if there is a local infection near the L3 L4 site, you cannot uh, put a lumbar puncture there, right? Just a second, we have some doubts. Okay. How will okay? Govindan is asking how it is painless procedure, sir. Through anesthesia given lumbar puncture is full. Uh, no, it's painless because first thing is you use a very thin needle, and second thing is the layers are there. No, these dural layers or the skin which is there, that is not anesthetized. I agree. Though you don't give a local anesthesia, you go direct in, but it's painless unless you hit a bone. When you are administering a needle, all these layers are very thin needle and fine needle, and the patient is put in a stretch position of forward bending, and then you put a needle slowly through the intervertebral space, and then you enter the layers of the spine. It can be painful when what happens, this needle accidentally goes and hits the vertebra. Only then patient experience pain. Otherwise, there is no pain as such. As far as I have seen, many lumbar punctures I have done, and I have given spinal anesthesia in my internship time, but there is no pain as such. So, is that clear? Okay, yeah. These are the problems. And here you can see a beautiful spinal needle is there. Different sizes are available. Here they have put a contrast into this, and the whole spine is lit up. This is normal procedure. If there is any growth, intravertebral protrusion, spinal root like pressure, it can be a filling defect like this. That is an abnormal myelogram. Okay, this is down here. Where we left near barium swallow, and I was explaining you how different things look. And I drew a diagram there, a rough diagram. I don't know how many of you observed. But could somebody guess what this could be? This is an esophagus, first of all, I'll tell you. And here is the stomach. And here we have had a thinning out. And all the barium meal which are given is here. What could be this condition?
Eclasia
Can
cardia.
somebody guess? Okay, could be an eclasia cardia, could be a simple stricture. Yeah, that's right. That is how you correlate. Okay, this is right. What is the problem with eclasia cardia? Why we call it eclasia cardia? What is the problem there? The problem in eclasia cardia is the lower esophagus. There are sphincters in the esophagus. Okay, there's an upper esophagus sphincter and there's a lower esophagus sphincter. Lower esophagus sphincter guards the stomach and and the esophagus. And the lower esophagus, when it's malfunctioning, it will either be too tight or it will be too lax. Both are problematic. If it is too lax, it will just send the acid out to the esophagus and burn the esophagus. And if it's too tight, it can present as a stricture. So what they call it as a bird beak appearance. Okay, this is what they call as bird beak appearance in achalasia cardia. Okay. Next, okay, this is the answer is given here. Here also there is an esophagus. What we can see is there is something that is grown, which is rough. Usually, it's like what we see in surgery is something that is painful is usually helpful. That is, if you have a growth which is painful, most of the times it is benign and it's not a problematic. If you have a painless one, rapidly growing something, that is usually a malignant cause of the malignant cancer, which is seen usually, not 100% though, just in most of scenarios. And here we can see there is a malignant growth that has grown into this. Probably he will have a history of a smoker or a tobacco chewer or an aracanite chewer who has come to you at his 40s or 60s where he is telling you that I cannot swallow food and I have a lot of stomach burning and I have lost so much of weight in so much of time either because of not eating or because of the cancer. And here we can see uh, this is a malignant constriction where the esophagus has become thin, mucosa is destroyed, mucosa is the smooth thing is gone. This is how a smooth mucosa and ulceration which can be there, which can be seen as filling defects, which we'll be seeing in the next image better. Okay, this is another bird beak or rat tail achalasia cardia appearance where there is gross dilatation of the esophagus. Okay, and there is a thin tail-like thing which is not that good. Usually, it will be like this huge esophagus will be there, and then it tapers like this, and then this is what they call as rat tail, bird beak, or whatever it is. Yeah, these are other images. We can guess it's a dirty looking. So there is some growth here and some collection. Yeah, these are all usually. This is looks like a malignant growth or something. Here we can see there is an esophagus which is there again rough and it has gone depressed maybe because of an ulcer. Next we'll move on to barium meal. Uh, Barium meal. Okay, barium swallow was for esophagus and proximal part of the stomach. Barium meal, where you can go up to proximal jejunum. As I told you, mainly barium swallow and barium meal are for upper GIT. So we can see the esophagus, the stomach, and the duodenum and proximal jejunum. How much roughly how much time does it take for the food to reach duodenum once we have food? Someone tell me so that you should know when you have given him barium meal and if you wait for too long, it is passed. The train is passed. So when around you have to take an X-ray.
5 to 6 hours.
Yeah, around 5 to 6 hours. That's correct. 2 to 3 hours is where you will be in stomach, and then after 3 to 6 hours, it will be passed to duodenum and so on. Again, as we have seen in barium swallow, what are the contradictions? Perforation, you should not give. Suspect aspirin, that is a bedridden patient. You cannot ask him to have a barium meal. Who is comatose, who is not fully oriented. If you ask him to have a barium meal, he will just aspirate. Aspiration is when the contents which are supposed to go into the GIT or the contents of the body itself, like mucus or saliva, is going into the respiratory tract. So respiratory tract infection takes place and it can lead to pneumonia. That is aspiration. It's a very problematic condition in non-oriented patients, aspiration. So you should always, a comatose patient who is maintaining his saturation should always be kept in a 45-degree reclining position so that he will not aspirate. Okay, this is 45, this is my 45 degree. I'm sorry for that. And if there is large bowel obstruction, why you should not give in large bowel obstruction is the meal will go there, the stay there, it will destroy the mucosa, then it will lead to a perforation and you will be causing another problem in case of the first problem. These are not that clear images. So, yeah. What are the indications you can give? Repeated vomiting is there. Heartburn is there. Heartburn. What is heartburn? What is heartburn?
Gastroesophageal reflux disease.
Yeah, heartburn is a condition where patient feels like there is burning sensation near the epigastrium, and it could be because of GERD, it could be because of simple gastritis, it could be because of excessive spicy diet which he had in the afternoon. Yeah, like that, these conditions could be there. And you can use this in upper abdominal mass. You can use it in abdominal masses, but you cannot use it when there's an obstruction because you want your contrast to get out as soon as possible from the patient's body. And then you can use it in gastroesophageal intestinal hemorrhages, and you can use it in obstruction. The indication for use in obstruction is a debatable issue because if the barium does not go out as soon as possible, it can lead to some problems such as peritonitis and all. So I do not strictly consider an obstruction as an indication for barium meal. And other thing is malignancies. You can use, we saw it in esophagus where it is presenting as filling defects. In a barium swallow, we were using a semi-solid or slightly solid diet, and in barium meal, we are using a uh, barium suspension. Believe me, barium is a very dirty, tasty looking thing, and it is not easy for the patient. You usually dilute it with a lot of fluids and then make him swallow. Uh, why we here once they are saying that once the barium reaches the patient's stomach, you rotate the patient because you want to line the stomach wall, and then more barium is given once the stomach is distended so that the duodenum and the jejunum can be filled. Question: what is hiatus hernia? If you know, you can answer. Otherwise, I'll tell it. I'm just trying to give as much information, maybe relevant, maybe irrelevant, so that one day something it may help you. Do you know what is hiatus hernia? Okay,
Stomach pushes up to the diaphragm.
hiatus hernia is, yeah, correct, exactly. Stomach is coming above the diaphragm. What is happening is normally it is like this. This is our diaphragm. Sorry for the bad image. And your stomach is like this. This is how it is supposed to be. What happens in hiatus hernia? This is moving up. So stomach has come out here, and based on that, there is different grade. Whole stomach also can be in the thorax sometimes. Okay, that is known as hiatus hernia. Why it is called as hiatus? Because this hole is there for the esophagus to pass, and through that hole only stomach is coming out, coming above into the thorax. And then we have GERD, then ulceration strictures. We have already seen how to interpret these. Okay. Could somebody tell me what has happened here? Here is the esophagus. Okay. Here was the diaphragm. What could have happened? Just a guess. This is the lining of the stomach. Okay.
Hiatus hernia, sir.
Yeah, hiatus and hiatus come into thorax. Correct. Exactly. Okay. Another wild guess. What could this be? Not hiatus hernia. Just look. It is looking dirty. First of all, once things start looking dirty, you should suspect. What should we suspect? Okay. Here we have one growth here, one stomach here, outpoach here. This is an ulcer, this is a growth. This is dirty looking growth, mucosa is destroyed, and the shape of the whole stomach is looking like bad. This could be because of a growth, an ulcer, a malignancy. Okay, this is how it will look. Uh, Next, what other uses of gastroduodenal ulcers we can use? Here they have put a comment about benign ulcers. Benign ulcers have less of foldings and they look more smooth. Something like this is always seen in chronic ulcers or in um, malignant conditions. I want to put a small note on this interesting thing. These are bezoars. What is bezoars? Yeah. What are bezoars? Trichobezoar. You know? Have you heard of stone formation in stomach? Yes or no?
Yes, sir.
Yeah, exactly. This is something out of stones. You can have it. Okay. Uh, what happens is usually in psychiatric patients, no, they eat their hair, and what happens
Eat your
in
hair.
stomach?
Yes, sir.
This thing goes. Yeah, they have their hair, and this hair collect and solidify in the presence of calcium or some food or something, and they form a shape of the stomach. Ultimately the whole stomach is full of this hard solid with hair and with food mixed thing, and these are known as bazaars. Okay, the trichobazar is what because of hair. If it's something because of something else, it is called as just bazaar. Okay, it is mostly radiolucent. Okay, that is it cannot be seen, but the problem is when there is a buzzer inside, this barium will go like this and line it. Okay, and if there is a crack in it, that will line that also. So you can suspect that there is something which is occupying the space of the stomach. Uh, Okay, next we'll go to one more condition, that is hypertrophic pyloric stenosis. This is also look. This will also look like a rat tail. Okay, first of all, pyloric stenosis. What happens is, but where is pylorus present?
Stomach.
Stomach.
Yeah, which end? Upper end or lower end?
Distal. Distal,
Lower
sir.
ends.
Lower end.
Correct.
Between 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 its two structures, stomach and
Duodenum.
Deodorant.
Duodenum.
uh, yeah, we have a structure here. So what this is infantile. Okay, first of all, if this is blocked in a child and you are feeding the child milk, what will child do? Just common sense. It is you are feeding the child. It cannot pass the duodenum. It will just vomit. Okay. Uh, Two conditions where I wanted to remember this. Vomiting is projectile. What do you mean by projectile? That is the vomitus is falling away from your body. So two conditions where vomiting is projectile is one is our pyloric stenosis, where there is stenosis of the pylorus and the vomiting is falling away from the body. And other thing is it can be because of raised intracranial tension or meningitis. Okay, this you have to remove. And here, when you have a stitch, it will look like a string that is going into the duodenum. This is infantile, and this is the picture for you. We have the stomach here, a very distended stomach, and then we have a duodenum here. But the problem is there is a stricture here. Stricture is nothing but a stenosis which is there. And one more good, nice thing what you can see is if you observe the baby carefully, child. Okay, there, there, there will be one mass formation, and this mass will move like this, and it will disappear. That is the peristalsis which is commonly happening, and it is seen from outside. I've seen a case like this. It's very nice to see, and the child was having all these symptoms. Then we did a release. If I'm not wrong, it's called as some Henley's release or something, where the stenosis is like this. So we give a incision like this and suture it like this. Did you get that? The stenosis like this. You do it like this and suture it lengthwise. So the thickness is increased. This is how you repair a pyloric stenosis, and this is how it will present. And this is the image. Okay, this is your turn now. What could be this? You look the stomach. Okay, what could this be? Dirty or clean? Come on.
It's 30, sir. Any mass?
It's Yeah, it's a mass, exactly. This could be a mass. Looks like a carcinoma. Why I'm telling carcinoma is not because I have added the image, because there are a lot of strictures, okay? That is fibrosis has taken place. Lot of filling defects are there. These are the remnants which are cut off, stenosis. And this is one ulcer, this is a growth that is there. And you can see minor ulcerations there, that is depressions there. This could be a growth that is there. Probably gastric carcinoma. Okay. We have seen barium meal. Now we'll see barium meal follow through. Basically what you're doing is you're giving a meal, You are giving an X-ray, you are seeing the image, then you are following where this thing is leading. This is follow through. Follow through is next after small bowel. We stopped at jejunum in Barium Hill. Now we are finishing the small bowel and ileocecal junction. We are going till there. See, when you are doing some follow through or meal, the part adjacent to it, like suppose you want to see the duodenum, the part adjacent to it is jejunum. Jejunum should not be blocked. So here we are doing a follow through. You do not want the colon to be blocked. Okay, this is the indication. Contraindication. If there is a colonic obstruction, you cannot do. And then there is suspected perforation, which is there every time. If you suspect perforation, then you cannot do a contrast radiograph. You should forget about it. Go for something non-invasive. What can you go if you have a suspecting a perforation? What can you do? Clinically, how do you diagnose? Clinically, what can you suspect? Come on, pitch in some ideas. I am a smoker. I'm not, but you think I am a smoker. I've come to you. How will I present to you with my perforation? That is, my small intestine is ruptured and my gastric contacts are out. How will my abdomen be?
Distended.
Yeah, my abdomen will be distended, hard, and if you touch me, I will hit you because that much painful. That is a guarding rigidity. That as you place your hand on that, the abdominal muscles will guard it because he knows that he's going to have a pain. And other thing is, you can have fever. Other thing is, he will be very. Have you heard of? I think I told you this Hippocratic face. Did I tell you? That is, you will feel as if that patient is going to die. That much it is a serious condition. He has to be taken into the OR immediately, and then you have to open it up and patch it up and give a thorough wash to prevent all the content from to go out. That is how the perforation will look like. And I was asking, what investigations can you do? Come on, I have come to you. I have perforation. What investigations can you do? We'll discuss this. Contrast we can't do. Can you do a plain X-ray?
Sir, endoscopy.
No. Why do you want to go for invasive procedure? Start from simple. We can't do endoscopy. I think it is not advisable. You need to prepare the patient, prepare the bowel, then you put an endoscope. It is not likely to be advised endoscopy. Why? Because you are putting a pipe there. Already my intestine is having a lot of ulcers. You will make more holes in that. So can we do an X-ray?
X-ray, sir. If not CT scan, sir.
Yes, sir.
X-ray you can do. We have discussed this. You are supposed to. I think Ganesh has the recordings. Okay. If I am going very fast or if you don't understand something, go back and read. X-ray you can do. What will be there in an X-ray? X-ray there will be air under diaphragm, and we have discussed this. This is when if you make me stand and take an X-ray, there will be air under diaphragm. Air under diaphragm is always sign of peritonitis because there is no air under diaphragm. Air is always above diaphragm. Lung is above. Okay. Then you can do a CT, MRI, ultrasound. All this you can do, which will come later. Which are complex investigations. You can do that later. Next indications. Well, one can you do when you have diarrhea, when you have idiopathic weight loss, when you have abdominal pain, when you have Crohn's disease. Okay. Then you have small bowel obstruction. If you have a colon obstruction, you can't do a follow through. But if you have the small bowel obstruction, you can do is what they are saying. Again, a debatable issue. I'm not going into that. GIT bleeding and a palpable mass and malabsorption. Malabsorption, you basically want to see again filling defects that are there or growths that are there. How is the procedure? Not important. Again, 500 to 800 ml of barium is taken, and it is swallowed every 15 to 20 minutes. And you can demonstrate up to the ileocecal junction and all the structures which are coming before it. Finally, you take ileocecal images. Okay. How do you interpret studies? We have learned this again, revision. Mucosal irregularities and ulcerations will present as filling defects. Okay, then fistulous communications will have like alternate loops, alternate pathways for the food to pass. Then displacement in extraluminal mass. What do you mean by extraluminal? That is outside the lumen masses will show as deflumetrum. Then in strictures that you can have narrowing, and always, and you should remember, if GIT is like this, if there is a narrowing, this side and this side can go in for expansion because this has to accommodate. And yeah, here we have an image where you have done a barium will follow through. Okay. This, now, is it normal, abnormal?
Prolapse.
No, not prolapse. You you do not do it. There is a stricture here. Okay, basically, I know it's a little difficult, but there's a stricture here. You can see this is thinned out. Normally, this is how it looks. This is also a stricture, but the image is not proper. It's rotated, so the full what you have given is in the stomach and the proximal part of the duodenum itself. Okay, that's okay. Okay. What complications can happen? We can perforate the bowel because when you put barium meal and if there is an ulcer, the pressure in the lumen will increase and it can rupture. And second thing is aspiration. Aspiration is it can go into the lungs. Lastly, we come to in contrast studies. We come to barium enema. Enema, how do you administer enema?
Through rectum.
Yeah. Have you seen any other enema other than barium enema?
Yes, sir.
Which others you have seen? Soap water enema you have seen. For constipation, we give soap water enema. Then there is something called as suppository. What is suppository?
So, which is placed in the rectum in the children, sir.
Drugs are placed in the rectum because children are uncooperative. You can keep paracetamol or any other drugs in the rectum. That is suppository. Okay. Okay. Here what you can do is there are two types: single, that is you use only one um, contrast, and other is double contrast. What you do is first you give a contrast, then you line the lumen, and then you give one more contrast. So you come to know how is the architecture of the internal lumen better. Indication for what is melena?
Dark colored stools.
Black tarry stools.
Yeah, exactly. Uh, I'm happy
Due to
that you are
bleeding in the
answering.
upper GIT.
Change. Yeah, exactly. Why it cannot be in the lower GIT?
Because that would
Lower
be red
GI.
I'll tell you.
and it would not clot
Yeah, uh,
and turn dark.
yeah. Why does it become black?
Sir,
Why does it
Clotting?
become black? If,
RBC
yeah,
rupture,
one.
sir.
Necrosis.
Okay, okay. That's basically because the hemoglobin is oxidized. Okay, if it's in upper GIT, there is one method of hemoglobin conservation. I don't know. Forgot the name. Yeah, where that hemoglobin becomes darker on exposure to oxygen. That is, it becomes oxidized. But that much of time is not there if it is in the lower GIT. Lower GIT is from ligament of Ribs. What if there is a lower GI bleeding? No, how will it present? What is that called as? Frank red cherry colored stool or blood will be passed. What is that called as?
Hematosis.
Metochizia.
Very
Hematochezia.
good. Yeah, yeah. What is hematemesis?
Passing
Blood and
blood through vomitus.
In the vomitus.
Yeah. What is hemoptysis?
Coffin.
Blood through
Coffee.
sputum, sir.
sputum.
Sputum.
Yeah, exactly. Okay, that means more than enough. Very good. Yeah, then uh, one normal condition where you can have melena, there is no bleeding. I'm sure about it, but my patient is telling me that there is melena. When can he have that?
Due to food.
While which food? Can you guess which? I'll give you a clue. Because of one tablet, vitamin tablet or
Iron.
supplement, it's iron. Very good.
Yeah.
Fine.
Yes.
Yeah. Iron tablets have black colors too, so nothing to worry. You can send your patient back. Say thank you, it's working, and you go. And if you are suspecting any mass and large gut obstruction, is again a problem. Um, Toxic megacolon, you can't use barium enema because the megacolon, the colon is already swollen up, and there is the motility is drastically decreased. So you do not want to put another contrast there. Pseudomembranous colitis, again inflammation of the colon. Rectal biopsy done recently because there is a fresh wound there. You don't want to mess it up. How do you do the procedure? You do a cleansing water enema or a soap water enema. You clear the bowel, then you follow up to the ileocecal junction. Then you do filming, and then barium is removed out. Um, if you are putting one more contrast, that is known as a double contrast barium enema. Or this is not required. Okay. Interpretation of ulcerative colitis. Ulcerative colitis is there is multiple ulceration of the large intestine. What is haustra? Anatomy.
Dilated intestine.
Haustrations.
Haustras are found in the folds of large intestine, where the tenic
Yeah, the
of
folds of
ligaments.
large intestine are known as haustra. Like these things are there, no? Yeah, exactly. What is tinea coli?
Sort of
It's a
bands, I'm not
ligaments. Okay,
sure
they are
about.
tightening things that are tinea. Okay, no problem. In ulcerative colitis, these haustrations are lost because there is inflammation and it becomes like a tube. And fine granularities of mucosa, that is because of again ulcerations and inflammation that is there. Then there could be strictures. Strictures are we have seen things like this. What happens? The fibrosis and pipe stem colon. I told you it becomes like a cylinder. Okay. Then we have learned about malignant lesions. Again, eccentric growth. That is, they grow however they want, and then they occupy the most of the lumen. And what happens is because of this, the proximal part is dilated, and again you have mucosal abnormality. That is, haustra is lost, and you cannot differentiate so easily between tuberculosis. However, the most common reason for tuberculosis is ileocecal junction. That is, he is a patient of TB, and you are seeing the problem is in the ileocecal junction, and you do an enema or a barium meal follow through, you can suspect it could be because of tuberculosis. Next, we have Crohn's disease, in which you can see again multiple ulcerations, distortions of valvular commitment, and thickening of the mucosa. And there is cobble pattern appearance. That is, you have like this, and then one you have, then one you have like this. This appearance is seen in between the bowel loops, which is there, and malabsorption. That is, you can see that the barium is present in one region and it is not present in another region. This is and there is a free area. This is known as the Maillard sign, and you can see also see that there is jejunal dilatation because the motility of the colon is or the small intestine is reduced. So the jejunum is holding up all the barium. Uh, So coming to small bowel enema, that is, here what you are doing is you are going through the rectum and you are administering the contrast, not up to the ileocecal junction but up to the jejunum, where you want to see the distal part of the small intestine also. You put a tube and then you put the contrast through that tube, and this is how small bowel enema is known as. This is known as enteroclysis. Okay, the same thing again. That a tube is used. It's okay. The name is not important, and a guide wire is passed. This is uh, it's not through the nostrils. Okay, it is through the rectum only. I think they are showing it wrong. In the enema, you go from behind, and you through the swallowing action, the tip is reached to the stomach, and then you reach the pyloric column, and under the X-ray guidance, you go distal to the ligament of Trees, and then you do a put a contrast. But whether you it's called as enema, but it has to be given from the posterior side. But there is risk of rupture of the large intestine, which is there. So you can go through a follow barium means follow through, or you can give it through an enema also. So the quantity is not useful. It's given about 200 ml of suspension you give along with a lot of fibers, and then you follow it through the fluoroscopy. And basically for ileocecal spot film, you can take the small bowel enema. Again, the same indications are there: small tumors of small intestine, GIT, pain, diarrhea, GI bleeding, and mechanical obstruction. And as we studied again, contraindications are complete obstruction, suspected perforation, where you are not supposed to do a barium and massive dilatation because the peristalsis is large, duodenal obstruction, and gastrojejunostomy. What is gastrojejunostomy? You know, gastrojejunostomy. Okay. Gastrojejunostomy is where the stomach and the jejunum are connected either because there is loss of duodenum or there is some problem pathology in it. How do you interpret the study? Again, same loss of the foldings that are there, valvulotomatous, and featureless ileum. That is, there is no folds. There is only a tube-like thing. Malignancies or lymphomas, they act as dilations or mucosal abnormalities. Then there could be strictures and ulceration and the distal or proximal region in a TB, or if there is a fistula. This is a small bowel enema for you. You can see there are multiple breaks there, strictures are there, and again there is a pathology which we have found. Okay, what could be the complications again? Uh, Perforation, inspission, and transient bacteremia. Because in the barium, we have seen that suddenly the flora flourish for on a short term, so there could be bacteremia also. Uh, what is intussusception?
So please
Somebody tell
repeat.
me what is intussusception. Intussusception of small intestine or large intestine, commonly in small intestine. Intussusception is you are given a meal, which is a foreign thing for a body. Usually seen in children when they are fed milk, and after 6 months you start giving them food, that is semi-solid diet. What happens is this small intestine, basically because of peristalsis, this goes inside one another. That is, to be correct, it goes like this. This is known as intussusception. It can spontaneously become corrected, or it may need surgery sometimes if it is very tight. This is known as intussusception. Okay. Okay. Next, we have finished contrast based on barium, and we have finished bronchogram. We have finished myelogram. Basically, those two in a very superficial way. Next, we come to angiography. What is angiography? Come on, what is angiography?
So viewing blood vessels.
Angiography is the, yeah, you view the blood vessel with, and you see the main arteries, and you look for any blocks, any alternate pathways for blood, and any pathology in the wall. Okay, where where we can do, and for angiography we have to give a contrast. So the contrast can be given through a femoral artery, an axillary artery, or a brachial artery. These are the common sites. However, femoral artery is used more commonly. This is an angiographic image where you can see the arch of aorta and its branches. Please tell me what are the branches 1, 2, and 3. If you know, you have to tell me, or you can go back and read.
Brachiocephalic subclavian.
And what is the third one? one side, one is not there.
Carotid.
So basically, no, that's not carotid. You go back and read it. Okay, there is brachiocephalic and subclavicle, clavicular, but one side, one is not there. You go and see it, which side, which is not there. Okay, indications when you have vaso-occlusive diseases, when you have aneurysm. What is aneurysm?
Dilatation of blood
Dilation.
vessel abnormally.
Yeah, it happens because of the intimal tear or intimal damage it is there, and there can be atriovenous malformation and vascular assessment of tumor. What do you want to assess in? What do you mean by vascular assessment of tumor?
Checking the tumor markers in the blood.
No, not tumor marker. What you see is how is the blood supply of the
Blood vessels to the tumors.
yeah, that's exactly what you see. How much blood vessels are there? Because any property of a tumor is to have what is it called as formation of blood vessels? Neovascularization.
Genesis.
No, neovascularization. New angiogenesis is different terminology. Neovascularization is new vessel formation is known as neovascularization. So if you want to go back and cut it out, you have to know how much blood vessel is there and there. So you have to be prepared. So that is the vascular assessment of tumor, because some tumors such as thyroid are very rich in blood supply, and some others such as in the breast are not that rich in blood vessel. And congenital vascular condition. What is coarctation? What is coarctation?
So splitting of artery, coarctation of aorta.
Splitting is it's not splitting. It is basically the uh,
Narrowing.
narrowing. Okay, that is coarctation of aorta. And percutaneous interventional vascular procedures. If you want to do anything by entering through the vessel, you have to have an angiographic image before, because if there is an thrombus or some calcification which is there, you don't want to discharge it because of the intervention which is there. Uh, you, yeah. Contraindications when you have bleeding tendencies, that is the prolonged the bleeding time and clotting time and INR increase. You don't want to do it because you cannot control the bleeding. And if there is a regional skin infection where you are entering the femoral artery or a axillary artery, and cardiovascular diseases, because in congestive cardiac failure and MI already the heart is burdened, you don't want to burden it further and cause another attack. And other is hepatic failure, because a liver should be strong enough to take the contrast which you're giving. Okay. What you do is you put a local anesthesia at the site, and in children you go for general anesthesia because children are restless. And then the artery is punctured using a cell-dinger needle, which is used to enter the artery. Then the catheter is inserted through the uh, needle, and the vessel is entered and contrast is inserted. The aneurysm will present as a focal dilatation. Tumor will present as a group of vessels, and with the sorry, AV malformations will look like there is a connection between an artery and a vein. Through it, a rapid blood flow is happening. Hence, the contrast which is there in the vein will rapidly drain. Then we have a vascular occlusion, which will present as tapering, and later on there is collateral formation taking place, which can be seen on angiography. What is this image? By now, this is a vessel. We have given a contrast.
Angiography.
What? Can you repeat? I didn't hear
Angiography.
that. Yeah, it's an angiogram. What is the problem with it?
Narrowing.
The constriction. Narrowing.
Vessel wall is narrowed. Exactly. What can happen? What a doctor can do while doing an angiography is he can damage the wall. He can cause severe hypotensive reactions. Why? There are what when you have a blood pressure which is peaked up and you give a carotid massage, what happens? Why does the blood pressure decrease?
So please repeat.
You have a patient who has 180 by 100 BP, and I have come to me and you give me a carotid artery massage on one side. My blood pressure
Proprioceptors that are present in the carotid artery.
they are not called as proprioceptors. They are called as, I think,
Not
baro,
proprioceptors.
baroreceptors.
Baroreceptors,
Baroreceptor.
yes, sir.
Okay.
Yes,
If I'm not wrong, they are called as
sorry,
baroreceptors.
mistake.
Yeah.
Increased vagal tone, sir.
Yeah, that will cause the blood pressure to come down. But you should take care that when you're giving a carotid massage, you should not massage on both the sides. And carotid massage is also a risky thing in an older patient because his carotid artery is, how is the artery of old age person? It's thick, calcified, and it's full of like thickening plaques or cholesterol. And if you give him a massage, that plaque will go into his brain, and he will have problems. So in olders, it is not advised. So if such things happen, it can lead to hypotensive reactions, and then you can have thrombosis of arteries, embolus, and hematoma because of this thing, and vagal inhibition. What will vagal inhibition cause? Arteries will increase or decrease?
Decrease.
Decrease or increase? Up or down?
Decrease, sir.
What does uh, vagal stimulation cause?
Bradycardia.
Okay. How do you stimulate vagal now? How can you stimulate?
Parasympathetic stimulation.
Okay. No, it can be done by simple acts such as breath holding, singing, and such as that. But it normally doesn't undergo into vagal inhibition or stimulation so easily. Um, but these acts can cause vagal stimulation. Uh, that is called as Valsalva maneuver. Okay. Uh, Allergic reaction to contrast and damage to uh, nerves and the contrast. Now, what are the nerves which are present in the arteries known as?
Vasa nervorum.
Yeah, exactly. That is correct. What is the artery supplying the artery known as?
Vasa vasorum.
Vasa vasorum.
Very good. Yeah, nice. Next, we have finished myelography. Okay. Indications. What are the indications? You want to suspect there is a disc prolapse, or you can nerve root compression or intraspinal circle. Uh, what is the ideal thing you want to do if you are suspecting a nerve compression or a disc prolapse? Investigation of choice. This patient is having a nerve impaction. You want to do one test. This is the ideal investigation of choice.
So you mean physical examination?
No, investigation. No. Physical examination is clinical. Investigation of choice. MRI. Okay. But why we know that this person is having intraspinal or nerve root abnormality? Why are you going to do a myelography? When are you going to do a myelography? Basically, in MRI is the best thing to do, but you are still doing a myelography. When can you do that? When do you need to do that? Yeah, I'll finish the class by 5. Come on, speak.
Spinal cord misalignment, sir. No idea.
Spinal cord misalignment, you can go for MRI. Why do you want to do a myelogram? My question. Just think, what is MRI full form?
Mag magnetic.
You have a magnet there.
Magnetic
So
resonance
when
imaging.
Yeah, MRI, magnetic resonance imaging. We'll read about that later in next class. You have a magnet there which is causing the problem. So if you have a patient with an implant, a rod, a steel, or something else, or what is that cardiac pacemaker, you cannot do an MRI. So you have a patient whose root is compressed, you want to see. So you do a myelography. Okay. Okay. This is contraindications. Why it is contraindicated in papilledema? What is papilledema? If you have your phones in your hand, if you're fast enough also you can answer. Come on. Papilledema is nothing but the retina is swollen because of the raised ICT, usually intracranial tension. Okay, once already you know that papilledema is there and there is ICT, you don't want to put another contrast inside and spoil the show. So you don't do a myelography in when there is papilledema, and when you have done a resistant LP, because the sheath covering the spinal cord is not yet fully healed, and previous reactions if you had, you don't do a myelography. Somebody told me you enter to L2, L3, low osmolar, normotonic. What is low osmolar? What is low osmolar? What is
Hypertonic
normotonic?
solution.
What is low osmolar? Normotonic is equal to the tone of the
Sir,
blood.
hypertonic
Okay,
solution. Hypertonic
hypotonic,
solution.
hypo. Yeah,
Hypotonus.
Sir, hypo.
Yeah, osmolarity is lower than that of the blood, and it is normotonic. Okay, that is injected. Why do you want to inject something which is hypotonic and not hypertonic? What will happen? If you just drop water into the spinal cord,
Exosmosis.
spinal canal. Yeah, you don't want to increase the pressure further, so you use low osmolar. And then we tilt the head based on how much of the area you want to see. Then systemic puncture, that is, you do a direct puncture if the lumbar puncture fails. What is systemic puncture? I want you to go and read. Okay. Okay. Interpretation of study. If there is a disc lesion, you can have impressions. That is like this. The contrast is like this, and you have impressions like this. Then we saw the image looks something like this. And if there is a nerve compression or nerve cutoff, there won't be a continuation with the nerve. It can be. We saw a normal one, but that's how it looks. And intraspinal tumors are there, and there. This will look bigger. Of course, lesions will discuss the column and all that. Okay, what is this? Normal, abnormal. Firstly, normal or abnormal?
Abnormal, sir.
Yeah, definitely abnormal. What has happened is the spinal column is okay till here, but above this the contrast is not gone. That means there is some stenosis of spinal canal or some problem pathology which is lying there. Hence, the contrast has not gone up. Okay, complication, headache, convulsions. Okay, can be because of meningeal irritation. Why do convulsions occur? What happens in the brain? The brain surface gets irritated. Okay, that's why convulsions happen. Based on which area is irritated, that area going for convulsions or epilepsy. Increase in the lumbar pressure, and it can be hypotension. What is Cushing's reflex? Cushing reflex. Clue is it is related to intracranial tension. What is Cushing's reflex?
Sir, can you repeat the clue, please?
Clue is intracranial tension. It is related to something related to intracranial tension.
Pituitary involved.
Sorry? No, pituitary is not involved. It's just the name. it is seen in raised intracranial pressure. Okay, what happens is here, because of raised intracranial pressure, there is uh, less of blood that is going into the brain. So what happens is, you can remember as BP increases, but heart rate decreases. This is contact. Usually, if heart rate decreases, blood pressure should also decrease. But when there is an intracranial tension because of some pathology or some trauma, here in this questions reflect no, that is in head injury, heart rate is decreasing, BP is increasing. Usually, systolic is increased and diastolic is decreased. Okay. Spinal cord damage in cisternal puncture, that is direct puncture leading to the problem. Okay, that's something else. This is not there in your topic. They didn't tell me to teach you this, but endoscopic retrograde cholangiopancreatography is the name. What is this? Based on the name, can you guess what it is? Endoscopic retrograde cholangiopancreatographic pancreatography. Okay. From the pancreas, secretions go into the.
Sir, through colon, we are going to pancreas.
Exactly. That is
Okay,
where.
sorry, sir.
Through endoscopically, that's right. You go from the colon, you go into the small intestine, or you go into the pancreas, and then you inject the dye, and then you visualize the whole of pancreas, and like that you can visualize the gallbladder also. Okay. Uh, this is uh, this is called as Mirizi syndrome. It's not required again. What you have done is you have gone in. Here you can see my endoscope that is there. And I have injected the dye through the column into the hole that is there. This is the gallbladder that is there. Okay, but it has filled up till here, and there is something gone here also, but it has not filled the gallbladder. That means there is some obstruction here, possibly a stone. This is now a Mirizi syndrome. Types are not important for you. Next, we have. Can you see the stones here? You have injected the dye, and in the back there are white areas surrounded by black areas. These are stones that are there in the gallbladder. It's seen in ERCP, endoscopic retrograde cholangiopancreatography. Okay, again stones. Okay. What is this? What have they done? Right side. Nothing. The bile duct, they have increased put the contrast, and the whole bile duct and the bile canal that is there is lighted up. Okay, this is too complex. Not required. Okay. This now we have done dilated jejunal loops. We can see here. Normally, jejunum is not this thick. What do you call the endoscopic pin or the contrast into the splenic artery also. So you can see how much of the spleen, or if there is splenic artery stenosis or something. Here, what they have done is, what you have to remember is, this is right side, this is left side. They have put it into a splenic artery, and here you can see it is tortuous and having multiple stenosis, not well appreciated. Again, okay. Now we have your done. These are some basic things which you can learn from contrast. Sorry for the long lecture. Can you guess what it is? Left one
Sir,
first.
screen is not visible.
Oh, sorry. We'll finish before 5 if you answer first. Okay. Now is it okay?
Yes, sir.
Is it okay?
Yes, sir.
Okay. Okay, just a second. Okay. What is this? Left one.
Peritoneum.
You tell me what X-ray it is. Sorry?
Abdominal.
No, this is chest X-ray.
Mediastinum.
Okay, of course, abdomen is seen. Okay, abdomen is also seen. That's also right.
Mediastinum.
Here you have a this is the mediastinum widened, and lung is not seen. This lung is collapsed, and here you have a like patchy appearance. Could be pneumonia. Here, what you see, this is an abdominal X-ray. What you can see, how are the bowel loops, normal or bigger or smaller?
Bigger.
Bigger. What could be this? Because of
Toxic megacolon.
could be toxic melancholia or simple inflammation of the intestine. For okay. Next, this is the same thing again. What is this? This is your colon. This is more relevant to toxic megacolon or a sigmoid volvulus, what you call it. The whole intestine is grown bigger. This looks like a toxic megacolon to me. And this is again dilated bowel loops, could be because of peritonitis. What is this phase you are looking at? One specific kind of
Papilla
facial
edema.
appearance.
Cushion's face.
No. In peritonitis, we see one facial appearance. I told you. This is Hippocratic faces. Okay.
Hippocrates.
This is Hippocratic faces. Of course, there is facial
Hippocratic
edema,
face.
but yeah. Here they have. What is this tube they have put? I told about this tube. To the chest they have put. ICD. Okay. This is an intracostal drainage tube. Probably this is a patient who has got hit or fallen, and there is pneumothorax or something or a hemothorax, and they have put ICT, and the abdomen is having a perforation also. So his face is it's like a Hippocratic face. Hippocratic faces is like death-like faces, deathbed-like faces is known as Hippocratic faces. That is all for today. And any questions I would like to answer now.
Sir, is the
Give
contrast
10
used for
minutes more.
all techniques we used is same, or is it different for angiography?
It is different. Specific contrasts are there for specific, like barium is used for contrast in elementary canals. Okay, for angiography you have different contrast, and for bronchoscopy again you have different contrast based on artificial preparation and different companies, which is not required. What contrast we use, because it's basically called as contrast and you get it in the market. Next, any more questions? For GIT, we have barium. For angiography, we have iodine, like that. And for ERCP also, you can use barium. And for bronchoscopy, I think they use. I'm not sure. It's a complex of some cysteine. I think. Next, any more questions? Come on, any questions, or we'll end the class for today. It was a nice session. I am happy that most of you spoke, and I want the coming few classes. I think we have 2 or 3 more classes which are coming up. And how internals are over?
Yes, sir.
Yes, sir.
Viva is
Okay,
going on, sir.
Viva is also Viva is still going on for 2 weeks.
So one is left.
One left, sir.
Tomorrow is going to end, sir.
Okay. Okay, then fine. We'll end the class. All the best for tomorrow's Viva. Do well. I hope what some other things out of the book also we tell based on clinical things will help you. And yeah, all the best for tomorrow's Viva. Thank you for listening and thank you for giving me your 2 hours of valuable time.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Again,
Thank you, sir.
if you have any doubts, please WhatsApp or mail. My mail I've already given you. If anything is there, you can put it out. Next class it will be dealt with. Okay. And the next class topics I'll be sharing to Ganesh, and Ganesh will tell you on what is the topic. And thank you and take care.
Attendance.
Why all left?
Yeah, why everyone is leaving?
Yeah, those who are there, I'll get attendance. Okay. Roll number 1. Roll number 2,
Sir, present.
3,
Present, sir.
4,
Present, sir.
5, 6, 7, 8,
Present, sir.
9,
Present, sir.
10,
Present, sir.
11.
Sir, she was present. She just left.
Why they left? Every time we used to take attendance at the end, no?
Sir,
This time
actually, she was not having charge in her phone, it seems. She texted me, sir.
11.
Yes, sir, Alfia.
Okay. 12,
12 present, sir.
13, 13, 14,
Present, sir. 14.
15, 16,
Present, sir.
17,
Present, sir.
18,
Present, sir.
19,
Present, sir.
20, 20, 21,
Present, sir.
22,
22
22,
present, sir.
23,
Present, sir.
24, 24, 25,
Sir, present, sir. She is having network issue. 25.